want to just say that I think the one of the really rich parts of what we do as a department is bring a great cadre of visiting professors, and once again, Dr. Galante in the trauma division has made that possible for us. And talking today about an incredibly important topic that will affect the lives of all of us, and particularly the young people in the audience, thinking about how precision medicine influences everything we do. So I will turn the introduction of our distinguished visitor over to Dr. Galante.
Well, thank you. It's with great pleasure that I introduce to you Captain Eric Elster. He's a professor and chair of surgery at the Uniform Health Services University and at Walter Reed. I know typically I'm standing up here introducing a trauma surgeon. Captain Elster is a transplant surgeon who does some trauma when he's deployed. So I'm not introducing you to another trauma surgeon. We actually, as transplant, see we can be diverse in terms of folks that we bring in. Captain Elster is certainly what would be termed the triple threat. He is a extremely well-skilled clinical surgeon doing transplants at Walter Reed, but as I said, I have been deployed in the same area of operation with him and have seen his skills in trauma and critical care. He is an exceptional educator. He is leading the drive to sustainment and readiness within the military to keep all of our general surgeons in the military ready for deployment and being able to go when asked. And then he is a leading researcher. Captain Elster's visit is actually a joint visit with us and Dr. Myers with Precision Medicine. Dr. Elster conducts both basic science, translational, and clinical research. And we are very excited to have him here and to hear his thoughts and his work on precision medicine. So, Captain Elster.
Thank you, Joe, for that kind introduction, and thank you all for your partnership with us in the military. It's been long-standing, and those ties are deep, and they're critical to our joint success. So I'm going to talk to you this morning about precision medicine, which is the future, and I'll explain why precision medicine is important to us in surgery. I'll tell you what we've done with our program, the SC2I. Some of the challenges, some of the critical findings, and then I'll point out some examples where we're bringing precision medicine to the critical clinical decisions that we make. So what is precision medicine? There's some decent definitions. You could Google them or read some of the papers. So precision medicine seeks to improve tailoring and timing of preventative and therapeutic measures by utilizing biological information and biomarkers. Good definition. You can actually go on Wikipedia, and precision medicine is tailored medicine, personalized medicine, using molecular data, clinical data, but data to tailor a decision about a patient. And if you could think about just the history of medicine over the past 100, 150 years, medicine at the beginning of the 20th century was personalized to the physician. I did it my way. I did it Halstead's way. It was tailored to the provider. Then we went through this growth and we made evidence-based medicine, tailored to a population. We looked at a whole group, and what's the best way for the entire population? If you think about that, that was probably like an 85% solution. Now we're moving towards tailoring the medicine to the patient themselves based on the biology. So we're almost coming full circle, but in a different way. Why is this important? Because the way we practice medicine now is extremely expensive, especially in those sick patients, those patients that we find in the ICUs, on the trauma services. So here's our national healthcare expenditures per capita, and you can see that line continues to increase and increase and increase. And for those of you that have followed the Institute of Medicine, now the National Academies, and their journey looking at quality and safety, you know that each one of us will suffer from a diagnostic error in our lifetimes. And those diagnostic errors have a real cost. They have a cost in dollars, and they have a cost in care. Precision medicine actually offers us the opportunity to bend that curve. So if you look at the numbers, they're kind of staggering. I know you probably don't think about this, but what we do, practicing medicine, is the most complex and biggest business in this country. It's about 20% of GDP, so it's about $3 trillion. That's larger than most countries on the face of this earth. And in that $3 trillion, there's at least 17 billion, with a B, per year that are preventable expenditures. Now, this is recognized. I mentioned the Institute of Medicine, National Academies. They released a report now 2 years ago, improving diagnostics or diagnosis in healthcare. One of the things they point out in that is bringing precision medicine, clinical decision support tools, what we'll be talking about today, to the fore. And the government has recognized this, both in and outside of the military. I'll talk to you about what we're doing in the military, but President Obama launched the Precision Medicine Initiative to kind of rally people around the potential of precision medicine. And we think the goal is leveraging all available medical data to personalize diagnosis and therapies and support, because this is clinical decision support. This is not meant to replace the judgment that you've learned over your career or are learning currently. It's to help you make a better decision so you can reduce morbidity and mortality. And I think one of the important things here are those two things. All data, it's not just a single biomarker. It's not just clinical data. It's a combination of all that data and the support piece. So why is it important? I'm in uniform. Why is it important to the DoD? I just explained why it's important for our healthcare system. Well, it's important for us for several reasons. We run one of the largest healthcare systems in this country. The military health system is a $50 billion enterprise. We have 9.2 million beneficiaries across the world. So we have the same pressures that you face. But we also have patients coming back from conflict. And what we've learned is increasing the utility of decision-making in those patients returns them to duty and back to the fight sooner. So that's why we're interested in this. And that's actually how we came to this particular field. So I'll talk for a little bit about some of the lessons of war and a response to critical care. So in taking care of these casualties over a decade and a half, we came to the following hypothesis, which was that following massive injury, physiologic responses that were appropriate when applied locally become inappropriate and beyond regulation when systemically activated. It's a mouthful. But essentially what that says is teleologically or genetically, our bodies are well suited to low velocity injuries. You can get injured by a spear or shot with a low velocity handgun or bitten by a saber-toothed tiger. If that doesn't cause major vascular injury and you bleed to death or get super infected, that response turns on and it turns off. It's much like when I sew a kidney in, you get a local response. If I don't give immunosuppression, the kidney dies, but the patient doesn't die. However, what we've seen from the wars in Iraq and Afghanistan is we've taken an injury pattern that was not survivable in the past, and patients are surviving. And that injury pattern are these IEDs, these improvised explosive devices. These are a force of injury that without the body armor, the trauma systems, the liberal use of tourniquets, the damage-controlled surgery, the damage-control resuscitation, that tour de force of care that folks like Joe, myself, Travis know very well, these patients would die without that. But however, for these particular patients, when they come to us in our combat hospitals with a pulse or blood pressure, their died of wound rate is about 2 or 3%. However, what we find with them is that they are systemically heightened and they develop complications. And it's not simply the physical destructive nature of those injuries, but the body's response to those injuries that sets these patients up for a myriad of complications and a long journey to return them to where they need to be. So this is just a picture of some of those combat wounds today. And on the center here, that's that dismounted complex blast injury. So this is a patient who is on foot patrol, who has 3 amputations: high bilateral amputations, pelvic or perineums disrupted, upper extremity amputation. This patient will survive and actually have a very fantastic outcome, but the journey is long. And they pose a real clinical conundrum for us. So these are extremity wounds, amputation stumps in different combat wounded patients. If you look at these all look good. They're all nice, red, beefy granulation tissue. So this one here, this one healed. This one is critically colonized. The same methodology you would use, quantitative bacteriology in a burn unit. So critically colonized. This was critically colonized and dehisced. This was critically colonized and formed heterotopic ossification. For those of you that don't know what HO is, essentially it's a bony soft tissue that wraps itself around the amputation stump, becomes a real problem at that interface between that amputation stump and a prosthesis, and can be quite invasive. Heterotopic ossification happens in 65% of these wounded warriors, and 20% it requires another surgical resection to take care of. And this patient had all 3. Critical colonization, dehiscence, and HO. And these, as I said, all look good. So this basically points out there's something going on in these patients that you can't see with your eyes. And we decided in 2005, starting in 2007, to attempt to measure that. What's going on here? Can we measure it? And then can we use that information to make better decisions? So here's our problem, which I think I just phrased for you. Management of the battle-injured, trauma, and surgical patients remains largely dependent on traditional, visually guided, looks good, patient looks good, clinical decision-making. And if you think about in these patients, the trauma patients, the surgical patients that go to the ICU, it's an 85% solution at 110% cost. So what's one of the solutions? Develop these decision support tools using evidence-based clinical data with cutting-edge science to understand the underlying biology and guide the management of care. Can we measure those responses? Can we understand those responses? And then can we build tools that help us with those critical decisions? So in order to do that, we formed a consortia called the Surgical Critical Care Initiative that was focused on developing, translating, and validating biology-driven care, providing individualized treatments based on that biology, ultimately improving outcomes. But if you improve the outcomes, you reduce the costs. I'll explain that to you in a minute. And take that information and develop these clinical decision support tools. And ultimately for us, accelerate the return to duty. So we started this work, as I mentioned previously, with some initial thoughts in 2005, started enrolling combat wounded patients in 2007. The ensuing 5 years, from 2007 to 2012, we enrolled about 300 combat wounded patients. And we basically realized that, again, it's not the physical destructive nature of these injuries, but the response to those injuries that was critical, that we can measure that response, and then we could start to build the clinical decision support tools to support important decisions. But then we kind of hit a wall. Combat wounded patients started coming down, thankfully. And we realized that we need to translate this from the military environment in the civilian environment. And what we're hitting on was not just related to these extremity injury patients, but was relevant to all 6 surgical patients. So we went to our leadership in 2012, and they said, okay, great, we're going to support you. And we launched a program in 2013, the Surgical Critical Care Initiative, which is a federal, non-federal partner. And it's focused on everything that we talked about, building these clinical decision support tools, complex decision making. It's us, which is us at Walter Reed and USIS. It involves another military lab as a partner, the Naval Medical Research Center. It involves 2 academic partners, Emory and Duke. They were selected because of personalities, honestly. And then we actually have built a company called DecisionQ into the mix because we realize as we build these tools, we don't want to spend 4 or 5 years negotiating with another company to get these tools into the clinical arena. We want to do that concurrently. And this is kind of how we approach bringing precision medicine into the acute space. And this has kind of been an iterative process developed over a decade. But the most important thing is we start with a clinical indication. We start with a question. What problem do we have as surgeons taking care of patients? For example, in those combat wounded patients, when do I close that wound? Do I close it on the 3rd washout, the 4th washout, the 5th washout? Is my patient going to develop sepsis? Should I start antibiotics now or later? So that's how we basically tackle these things from the clinical perspective. So we start with that clinical indication. We make sure we make it with a protocol. Now we have kind of an omnibus protocol called the Tissue Data Acquisition Protocol that's synchronized across all of our sites. So it allows us on the fly to come up with a new question and then start to answer it. Then we enroll patients, we process them and develop samples, run assays. Data management. I'm going to spend a lot of time talking about this data management piece because it's really critical to success. We do analytics and modeling, and then we deliver those clinical decision support tools. This is another critical piece, this analytics and modeling. This is something that can't be done in isolation from us as clinicians. You can't give this data over to the bioinformaticians and statisticians and say, hey, go make a model. They'll come back with a great model that's clinically irrelevant. So we need to be engaged in this process. And actually, it's not that hard. So this is how we've kind of approached this from the point of view of those critical decisions. So this is an injury cycle. Could be a wounded warrior. Could be a wounded warrior. Could be that sick patient with necrotizing pancreatitis. Could be the result of a domestic terrorism incident. Doesn't matter. As you guys know, these patients go through a phase of acute resuscitation, critical care, and definitive care. And this cycle may be a week, maybe a year. All along that way, there are critical decisions that we make that have a downstream effect if we get them right or wrong. So we've attempted to tackle those decisions by building these clinical decision support tools. So for example, we've already fielded 2 tools. One is a massive transfusion protocol done with our team down at Grady. And this predicts whether you activate the massive transfusion protocol or not. That's always a question. Hey, is this patient sick enough? Do I activate that MTP protocol? Because if you get that wrong and you overactivate it, there's a dollar cost to that, and there's also a risk of overtransfusion. Invasive fungal infections. This is really unique to our patient population, but because of multiple factors, the severity of the injury, the environment for which those patients are in, Dr. Galante knows this very well, having been in Helmand Province, those patients are at risk for invasive fungal infections. The problem here is if you wait for the ID folks to say you can use those antifungals, you're already behind the ball. So we've developed a tool based on clinical data that lets you make that decision in theater. Severe traumatic brain injury. Not diagnosing severe TBI, but helping the neurosurgeons make those critical decisions within patient, taking care of patients with TBI. Does the patient have vasospasm? Do I need to treat it? Do I take the ventric out? Do I put the flap back on? Those are the decisions we're working with around severe TBI. Pneumonia and VTE. Can we diagnose VAP or pneumonia before the standard test? Can we diagnose VTE ahead of time and start anticoagulation early? Physiologic monitoring. What about all that streaming data that's coming into the ICU environment that you look at for a second and it goes away? Can we predict decompensation ahead of time? So you're on ICU rounds, tell you ahead of time, go look at the patient in bed 4. They're at risk of respiratory compromise within the next 4 hours. Being proactive rather than being reactive. Wound closure. That question I brought up previously in that wounded warrior who's on their 4th washout. Do they need 3 more washouts? Or can I close that wound? Or can I close that open abdomen now? Acute kidney injury. This is an interesting one. We have some very nice data that predicts acute kidney injury. What we haven't been able to do is mate that tool up with an intervention. So some things you can predict, but you also need to mate it with an intervention. And of course, that heterotopic calcification. I mentioned the cost piece, and as part of our approach, We do business case analysis on all these clinical problems because we're trying to make essentially an investment of our time and effort into these things. So these are some cost estimates of the enhanced decision making across sepsis, wound closure, pneumonia, acute kidney injury, bacteremia, VT, zero TBI. And you can see the cost saved potentially on an annual basis versus the military. So you're talking in the military, for us, we can, if these tools work, we can save over $100 million a year in our system. And that translates up to $10 billion a year in the US healthcare system. Now, even if that would be a home run or a grand slam, even if 3 of these 7 tools work, we've already returned on the initial investment. So I'll give you, I mentioned the dollar cost. There's another way to look at this. Our bosses are the military line leaders, you know, the generals and admirals that go to fight the war. They're very interested in these numbers because the medical budget is 10% of the DoD's top line budget. So that's a real number. But they're also interested in this, is what is the impact in the battle space of one of our decisions? You know, we tend to think of ourselves in medical as working in isolation. But for example, if we make a decision to transfuse or not to transfuse, there's a whole logistical tail that comes with that. And that logistical tail could be used for something else, bringing bombs over, flying combat missions, rather than bringing more blood. So we actually did a war game. We used a conventional war scenario, which was NATO versus Russia and Belarus. And they have these things in the Pentagon where they plan for years. And this was a conventional war with lots of casualties. We said, what if we had this massive transfusion protocol tool that allowed us to accurately predict the need for an MTP? And what we found is if we had that tool, we could save in this 30-day war game 33,000 units of platelets, 20,000 units of FFP, 33,000 units of PAC cells, 20,000 units of FFP, 15,000 units of cryo. This all translates into 132 pounds of stuff that needs to be flown over from the United States to Europe, which requires 21,000 pounds of jet fuel. That'll allow us to do 616 more medevac missions or 88 more close air support missions with a full entourage of weapons. So one decision, do I give this patient a massive transfusion or not, has a huge impact. So I talked about why we need precision medicine. I talked a little bit about the impact. I want to spend a little bit of time talking about how you get there, because this is really, really important. You need to standardize, aggregate, and have compliance. This is critical to being successful, and I think this is where some of the precision medicine efforts have failed in the past. So compliance. So for us, if you think about, we run these biomarker tests. We run, I'll show you in a minute, but we run protein tests, we run flow cytometry, RT-PCR. If you run those in a research laboratory, the test-to-test variation can be up to 40%. You run it one day, you run it the next day, you get 2 different numbers. That is not acceptable for clinical practice. That variation needs to be closer to 10%. So what we've done is we've actually changed our approach in those research labs. We run our research labs according to good clinical laboratory practices. We have over 150 SOPs. And we're actually moving towards CAPT and CLIA. Those are the same certifications that you have in your clinical labs for our sites where we run these advanced biomarkers. That was a change in the culture. The research culture says, well, I ran this assay yesterday, but I think I can do it better. I'm going to tweak it. No, you can't tweak it. We've gotten to the point where it's standardized. And that, again, is a critical part of this. Consortium-wide assays. Not everyone can do everything, so you try to divide between your partners who has expertise in what space. Protein expression, gene expression, flow cytometry, quantitative bacteriology. Some of these things you need to do at every site because there's a time-dependent part of it. Some of these things you don't. But most important is data aggregation. So, for example, in our standard protocol, we have over 8,000 clinical and biomarker data points per patient per time point. And you'll see in a minute, we collect data at multiple time points. So far, I think we have over 100 million data elements across just 600 of a subset of these patients. That's a lot of data, but it has to be aligned and aggregated. Because if it's not, you can't use it to build real models. So this shows you kind of what our studies look like across our sites. These two studies, the WoundVac and the ProCT, are those 300 legacy military patients where we made our initial observations. Our tissue data acquisition protocol, which is over 600, which is enrolling at all 3 sites, and we enroll anywhere from 6 to 12 patients per week across our studies, across those 3 sites. This is that core protocol that everything's standardized against. The WoundDX is a parallel study to Wounded Warriors, but in civilians. I mentioned the massive transfusion protocol, and I mentioned the TBI protocol. And you can see we track this on a weekly basis. But you can see where we started here in 14 with no patients, we've been able to ramp up pretty quickly. Now, we built the consortia as we enrolled patients. So we kind of framed the house, then we started living in the house and working on the house. And we're at the point now where all the interior finishing's done, the guy's in, installing the sound system and making the remote work, is essentially where we are with this approach. So how do we approach, each particular patient? Well, we start with a critically ill patient that are basically our entry point for these patients are those that are sick enough to go to the surgical ICU. We tend to aggregate around polytrauma patients, complex cardiac thoracic surgery patients, because that's what 2 of our institutions bring to the table, but other sick surgical patients as well fall into this. We do both time and event-driven data collection. So every patient, T0, T1, T3, and T7 every week till discharge. Obviously, the trauma patients don't have a T0. They start with T1. So they all get standardized collection of clinical and biomarker data. They also get event-driven data collection, and those events are defined. Return to the operating room is an event. Requirement of renal replacement therapy is an event. Escalation of care is an event. You get placed on a ventilator. Then they all get their data collected again, including the biomarker samples. And what do? We look in the serum for cytokines, chemokines, proteases. We look for danger markers, toll-like receptors. We do flow cytometry. We actually capture the white blood cells in the PACS gene tube, so we can do PCR-type assays on the blood itself. For those patients that have a negative pressure wound therapy system, an open abdomen, an extremity wound, even chest tubes with not just the effluent coming out, we'll collect that effluent and measure the same. And then if they have a tissue that's accessible, again, an extremity wound, an open abdomen, we get tissue biopsies and we look for wound healing associated genes, osteogenesis associated genes, pathogen specific PCR, and you'll see some deep sequencing. So we have over 300,000 specimens that are in our TDAP protocol that are across our consortium. And then from that, we run our protein expression, gene expression, procalcitonin and flow cytometry and sequencing. What's interesting out of this is the hardest thing to do is the protein expression and to basically synchronize that. However, that has the most predictive power because it's most distal in the process. So actually, gene expression is pretty easy to standardize. Flow cytometry is probably not practical at this point to make clinical decisions. Sequencing, is fairly easy to standardize, but a lot of data. The power for us so far has been in protein expression. And the data alignment and aggregation. I mentioned this before. I'll hit it one more time because it's so important. So we have site-specific QA and QC, aligning the data and making sure those data elements are correct. So this is essentially a registry-level process, just like we talked about this morning about NSQIP. Our research coordinators are trained like registrars. So they go through the records, and if the patient has pneumonia, the patient has pneumonia based on standard criteria. If there's a question, there's a tending level review for each of these. So it's critical. If we're going to build a tool that predicts pneumonia, the patient better really have pneumonia. We do not use administrative data at all in this process. I think we all know the problems with administrative data. So that data gets 100% QA, QC on the site itself, and then gets transferred to a clinical data repository, which hangs out on the Amazon Web Services GovCloud. That's a cloud that meets both DoD and all of the healthcare environment rules. Then it gets aggregated and aligned across all the sites. And then that data gets transferred to an informatics core that can start to address those questions. So remember, you start with that clinical question, then you can bring it back to the data, and we work with the bioinformaticians and statisticians to develop these models. And the goal here is to leverage all of the available data, the clinical data, the biomarker data, radiographs, and our intake form for our TDAP, we have over 2,000 clinical variables that we capture and develop these predictive algorithms. And it's not necessarily, not a one-size-fits-all approach. This is a list of all the different approaches to these machine learning methods, Bayesian belief networks, random forests. Some are transparent, some are more opaque. We'll use some to look at the features that go into a model, and others to actually run the model. So you have to have the facility to use all of these approaches, and then start to address those clinical questions that I talked about. So I'm going to switch for a moment now that you've gotten the background and give you just a few examples of what we're doing in this particular space. So if you look at kind of just the big picture, I mentioned before that there's this response and it goes unchecked. So this is, tissue damage, injury blast, tissue damage, the immune response, and then end organ injury. And what we're trying to do is measure this response here. So I'll give you 3 examples of how we do that. One on the very basic side for biomarker discovery. One starting to apply a cohort of biomarkers to a clinical condition. And then the last, we're actually developing the tools and what each of those processes look like. So this is a study where we decided to look at a small cohort of wounded warriors that were matched to use gene sequencing, to use RNA sequencing. I think you all have heard a lot about sequencing. Generates a lot of data. We hadn't used it to this point, and we wanted to see, hey, what's the utility of using sequencing? So we took 18 patients, initial debridement, intermediate debridement, 21 wounds, and came up with matched patients that 10 were healed and 11 were dehisced. And these were patients that had amputations, open fractures, and STIs. They had multiple wounds, 18 patients, 21 wounds. And then when we looked at the quantitative bacteriology, again, that's the same CF colony form units per gram of tissue that you would look in a burn unit. 34% were colonized and 66% were non-colonized based on that quantitative bacteriology. When we looked at those colonized wounds, you can see they're basically gram negatives, only a few gram positives, and this is kind of what that polymicrobial community looks like in those patients. So what we did is we took that tissue, we put an RNA later, did all the steps to extract the RNA, and then ran it through this next-gen 500-gene sequencing machine. We have the luxury at USN to have one of the largest genome sequencing centers in the world, and these people can do this. They could turn this pretty quickly. And then we looked to see what came out of this, and then to do some follow-on studies to verify what we saw. So when we did this, we saw that colonized wounds exhibit more of these differentially expressed genes. So these are the non-colonized wounds, and the way you look at this is with things that are upregulated significantly or downregulated. You can see in the colonized wounds, there's 182 of these things that are downregulated and 375 of these things that are upregulated. What were these? They were related to muscle system, cytoskeletal development, tissue, cell homeostasis, cell biology, so kind of basic pathways. These are the gene ontology or the GO terms. And if you start to go back and look at those GO terms, they start to aggregate into, for the colonized wounds, proteases, innate responses, inflammatory responses, and for the non-colonized wounds, angiogenesis and growth factors. So then we went back and took those same samples and did transcripts or mRNA on those to follow up what was done on the RNA sequencing. We're bringing it, if you remember back to how your biology works, that's kind of the next step. And we saw that whether it's the initial debridement, the intermediate debridement, or the final debridement, we saw in colonized versus non-colonized upregulation of things like LBP and 2 of the toll-like receptors. So this is a biomarker discovery piece. We went through this process of starting with the clinical problem. These wounds failed, these dehisced. Then we went through the whole gene sequencing thing and started to target in on what are some pathways we weren't sure about. And then we've come up with these 3 potential targets that we can plug back in on the clinical indication. So the next phase is, bringing that clinical condition back and starting to link things like inflammation to clinical care. So these are a population from our Tdap group. So these are military and civilian patients. This is 226 of those 660 patients. It's a mix between, it's military and civilian patients. There's 175 trauma patients and 51 non-trauma patients in this cohort. And we looked at protein expression of these different biomarkers. And you can see there's pro-inflammatory cytokines, anti-inflammatory cytokines, chemokines, essentially the signals that let cells talk to one another. And if you look at kind of common patterns, you could see between the overall population, the trauma population, there's overlap between eotaxin, GM-CSF, and the chemokine MCP1. There's a few that are unique in the total population, some that are unique to trauma, and then some that are unique to non-trauma in those patients that develop ARDS. So again, you can start to get a hint of where we can go, what's related to this particular clinical condition. And then ultimately what we're doing here is building these predictive tools. So here's a tool that we've built, that developed, that predicts venous thromboembolism. So this tool was built in a cohort of 73 military patients, that 9 had VTE. We've done this work initially in the military patients, now we're replicating it in those civilian patients. And you can see this is just a schematic of what one of these machine learning algorithms look like. This actually is a Bayesian belief network, although the features were selected with another methodology. Here's the outcome. Here are the drivers, and you can see it's clinical drivers, so age, that ISS score, the wound volume, the wound surface area, and then some of those biomarkers, VEGF, IL-1 beta, MIG, FGF, and they all come together to predict that outcome. And you can see we're on a receiver operator curve, an AUC of 0.881 with a nice uprising slope seems like a very nice way or very good characteristics for a receiver operator curve for a tool. We actually don't stop just at RC curves. We actually do something called decision curve analysis on all of these tools that tells you the utility of using these in the clinical environment. Then another example is pneumonia, actually the same patient population. In 73 patients, 9 patients that had pneumonia. You can see the drivers here. Again, a mix of biomarkers, clinical factors, including transfusions. And you can see the AUC here is almost 0.9, high rising upslope. Also on decision curve analysis, a very nice looking model. And then if you look at these and you start to see what's the overlap between these, you can see here's the drivers for the pneumonia model, here's the drivers for the VTE model, and some of the common elements are actually some of the clinical things. The wound, size of the wound, the number of blood transfusions, the injury severity. So you can see there's common pathways for many of these things. And then finally, after you kind of work, develop the tools, you validate the tools, you have to deploy the tools. Because at the end of the day, there's some really nice science here, we can write some nice papers, but we want to give you the things you need to make better decisions. So we've deployed, I've mentioned these already, 2 tools, and this is what they look like. This is the tool that predicts invasive fungal infections. This is a web-based tool, and you enter things like about, does the patient have an amputation? What's their base deficit? Did they get a colostomy? What's their shock index? How much blood did they get? Did they have pelvic injury? Their SOFA score? And what's interesting about this is there's boxes here for unknown or yes or no. Because these tools do very well, or our approaches do very well with missing data, and that's just what we do clinically. You know, when we see a patient that has flank pain, pyuria, a fever, we diagnose them with pylon and give them antibiotics. There's a lot of stuff we don't know, but the data we have is good. The tools work the same way, and you need your tools to do that because in the clinical environment, you won't have all the data points. So this tool will predict the patient's risk of invasive fungal infection and then give you a recommended action. Your risk is greater than 33%, therefore you should start this patient on systemic antifungals. You'll note this is a web-based tool, and I'll get to that in a second. This is the MTP application, the master transfusion tool. You can see for this, basically very simple things, male, female, mechanism, base deficit, heart rate, blood pressure, predicts MTP. This is a smartphone-based tool. Now, those approaches are nice, but they're not the future. They're kind of an intermediate step. The future is embedding these tools within the electronic medical record. Like it or not, we all use electronic medical records, kind of the crux of how we look at data. So what we're doing is actually for the MTP app, in our system, some of our places use Cerner, some of our places use Epic. We're actually working with the infrastructure that now is coming on board to insert these clinical decision support tools within the Epic and Cerner environments. And within the next month, we'll have that master transfusion protocol up and running in the Cerner environment, and then we'll replicate it in the Epic environment. That's a big step because we're coming in with something that was developed on the outside and putting it in within the electronic medical records, and they've been extremely proprietary up to this point. So the future is for you to have a dashboard within the EHR that shows you a prediction of all these things. You basically, you ask, hey, what's my risk for VTE? Should I close this wound or not? Is my patient at risk for pneumonia? You'll have a risk score, and it'll help support your clinical decision making. And we'll move from today, which is very retroactive, very visually guided, to the future where you have the information in front of you at those specific conditions, and you're really personalizing that patient's care. With that, I'll end. I just want to thank the team members. This is a huge effort. There's essentially 50 FTEs divided over 100 people doing this across all the sites. We have 2 meetings a year where everyone comes together, and this is just a snapshot of the folks that are doing this. These are a bunch of really bright, dedicated people, and I just get to tell the story. Thank you very much.
Well, that was an absolutely brilliant body of work and a brilliant presentation. I think I'm reminded of something that people said about the late Judah Folkman, who would have won the Nobel Prize for angiogenesis if he had lived, is that it's not just in doing good science, but it's being able to communicate it in a way that it makes it accessible to everybody. And I really think that you did an outstanding job doing that. And this is without a doubt the future of how all of us are going to work. Decision support is not going to be now up to date anymore. We've really moved beyond it. So we do have some time for questions, and if you'd be willing.
Of course. Sir.
You have some unique large databases. Have you employed some of the more modern data analysis methods, neuromorphic chips, true north chip, that sort of thing, in studies of relationship of genetics to biologic phenomena? That pattern recognition piece is really difficult. You may have, observation A, B, C, and D. None of them on univariate analysis correlate with an outcome. And yet, when all of them happen, a very high percentage of the time, something magical happens. And it's very difficult to tease out that sort of information using conventional statistical analysis, but these neuromorphic chips are great at multidimensional analysis, pattern analysis, basically.
So the question is, have we used multidimensional pattern analysis with this? And I'm going to ask you about that chip later because I have no idea what that is. Remember, basically, I'm a guy that cuts people open, but we do exactly what you're talking about. Because when I'll go to our bioinformatics folks and say, listen, tell me what I don't know. Let's look at this data in a different way. And what we've done is combine the machine learning approaches, some for feature selection, some for model development and refinement, and kind of cobble those together in a way that seems to work. But I'd be interested to look.
This latter tool would be more valuable for model development because you're going to have something that you can export to the field in a useful way. And I don't think these chips and technologies are there yet, but for model development,
Okay, I'll catch you offline.
Give you a reference too.
Thank you for the wonderful talk on precision medicine and trauma that we wouldn't really sort of think about. I have a question in regards to your war games modeling, which is very fascinating, looking at the savings and sort of the resource transitions by preventing blood transfusions. Obviously in healthcare we also do some similar modeling, looking at downstream revenue from a new system line or service line, or cost savings from a service line, and those sort of hypothetical predictions of downstream revenue or cost savings oftentimes don't carry a whole lot of weight. In the military world, that sort of modeling, do superiors look at that and say, wow, this is a valuable intervention or asset?
So the question is, when we did this business case analysis based on the logistical tail, and we take that, we sell the program. Does that pay off? It does. This is, especially if you're getting funding with a large investment of dollars, it's salesmanship. And you have to be able to tell a story and sell that story. That in and of itself alone won't get you very far. But woven in the picture, and you remember oftentimes when you're selling this or telling the story, there's different audiences. Some members of the audience will get it completely and that'll resonate with them. Some it won't at all. So I think I think in the modern healthcare arena, if you're not talking about the dollars, the tail, you're not going to be successful. So you need to incorporate that in your approach, but it can't be your only approach. I think that people get lost and chase and say, well, we're going to save money, and then they forget the reason we're here is to take care of patients and improve outcomes, and that's kind of the crux. That helps with that, but that's not shouldn't be your focus. Sir.
Thanks, Dr. Elster. Great. Again, enjoyed hearing it. A comment and just a question. My comment is more pride about our UC Davis surgeons. We really enjoyed bringing together both our trauma surgeons, Dr. Galante, and the burn surgeons, and Dr. Palmieri and Dr. Stewart at David Grant Medical Center to think about the complex trauma you described with superimposed burn and TBI, which really complicates the outcomes and changes and you alluded to that in some of your slides by really the integration of having to think about TBI with the kind of competing inflammatory and fluid resuscitation status. So we'll maybe get a chance to talk about that later.
Yeah, and we're working with the ISR, the Institute for Surgical Research, to enroll burn patients down there. We actually have a protocol that's finally approved, but it's been honestly a paperwork drag. The regulators will kill us all.
We're not familiar with that. Dr. Brown.
I just had a question about the evolution. So as you look at the biomarker profiles and try to incorporate that, the signal to noise ratio initially is going to be a little bit high, but I think you mentioned machine learning, and as far as how you're going to evaluate that, I was just wanting to hear a little bit more about where you are with that.
Yeah, so you start off with this. The question is, hey, how do you take this big pool of data with a high signal to noise ratio and come out at the other end with something that's clinically useful, right? And I mentioned this before, but it's really critical that we as clinicians are part of that process. I'll give you one of the examples. In the tool that predicts wound failure, if you give all the data to the bioinformaticians, they came back with this great model, and it predicts wound failure. But then you say to them, well, the patient has 3 wounds. Oh. When we sat down and did it with them, and we said, okay, throw in the effluent, not because it adds predictive power, but it tells me laterality. It tells me it's, the left leg versus the right leg, or the wound on the thigh versus the calf. That becomes very important. So one of the keys is having us involved in the process and do it with them. And then, essentially using different modalities, as we just mentioned, to sift through the data and come up with, what are the features or what are the drivers of that particular outcome. And then there's a lot of work by the statisticians, by bioinformaticians, working with the programs to start to build these models. And you have to develop a common language where you understand enough of this non-traditional statistics to have a conversation. And they start to understand enough of not just biology, but clinical care. I think that's kind of the secret sauce, honestly.
Very nice talk. For your clinical decision-making tools, how are you disseminating them and implementing them? And then how are you measuring the actual?
Great question. So for these tools, how are we disseminating them? How are we measuring them? Their effectiveness, essentially. So we haven't 100% figured that out. As I mentioned before, the tools that we released, the one that's on the web for the invasive fungal infection, for that tool, our approach with that tool which is very specific for a military population, is it's within the clinical practice guidelines of the joint trauma system. So we have these clinical practice guidelines. There's one for invasive fungal infection. So it's in that. It gets presented at all the meetings and talked about. And then we have a feedback form. Hey, you use this tool, let us know how it worked. That's a very, basic approach to that. But this was for a very small population. The ultimate goal, as I mentioned, is to inject these within the electronic health records and then link them back to the outcomes. And even because you're going to eventually have to monetize and sell these things, even in that, you consider that as you build your business case strategy, that you sell these things at a potential discount to different hospital systems as long as they give you the outcome data. Because what these models or tools have the ability to do is iterate, meaning they can get better over time if they get accurate information back. So critical in the future in delivering these things is not just measuring their use, but actually measuring how they do in predicting those outcomes. And there's two ways to approach this moving forward. One is a highly regulated pathway, and that's what we're doing with our wound tool. We're going through the agency. We're going through an IDA PMA pathway for that, and that has its own reporting structure in it. The way that most people have gone is a non-regulated pathway. Essentially, I'm going to release this as a calculator. That's what we did for the invasive fungal infection tool. Or we're going to make this into essentially a CLIA wave test like they've done in oncology with like the Mammotype or the Oncotype DX, where there's really no requirement from the company's point of view to capture that data and report it. That's probably not the way to go. Sure.
That's a great talk, really the future of how we are going to deliver medicine. One of the things that we worked on in a separate project similar to this, trying to use not only biometric data from the patient, but from the EMR as well, was getting it so that you didn't have your providers getting all this fatigue from different dashboards
Alerts, right.
in the EMR, but to create a feedback loop that was automatic so that, say, for example, you have a patient that had high risk for cubitus ulcer, the algorithm took into account their BMI, their smoking status, their current glucose finger sticks, as well as the pressure and the duration of which they were sitting on whatever's part of their body, and then creating an automatic ping in some way, either to their phone or to something else, to make you move the patient or do your intervention, and then having that feedback loop go back into the record, into our algorithm, so that you can continuously improve care around that time. Is there any thought to taking that sort of data and creating a loop like that?
Yeah, so the great question about essentially alert fatigue, right? We have all these things, and they warn us that your patient's at risk for this or that. For what we're doing, we're trying to tie the tools to those hard decisions that we have to make as clinicians. And okay, my patient is at risk for X. Well, what can I do about it? I think that's been the disconnect with some of the tools that are out there. I mentioned acute kidney injury. Like, we have a really robust tool that predicts AKI. Okay, great. What am I going to do with it? I really don't have an intervention that I can mate with that. I think that's really the key, is to you putting these tools with the therapy or the intervention that can make a change. So if I can tell you your patient's at risk, real risk for pneumonia or VAP, then you will do things, start on antibiotics, change their VAP bundle. So there's something you're going to do to that patient. The wound thing is a great example. Open abdomens. Hey, you got an open abdomen. Should I close the abdomen or do a planned ventral hernia? That's a critical decision. So I think the more we couch these in decisions that we have to make clinically, we won't have that fatigue because we're helping with the difficult problem. Sir.
Well, I was going to comment, very interesting topic. But the assumption is you're going to save money. And what you've done now is protein analysis, gene chip expression, all these things are going to increase the initial cost of healthcare, you don't make or reduce errors, so you're going to really save money. So how do you improve the proof of concept that I'm going to save money by improving decision making? And that's going to be the tough zone, because all these things, not every hospital can do protein expression and gene expression.
So I would step back a second and say the assumption is we're going to improve care. But in the space of, you know, a healthcare system where there's essentially no new dollars, you have to be at least revenue neutral in that mix. So, you know, how do you get over the hospital administrator that's going to say, well, why am I going to purchase this new capability? The first thing is a lot of these assays, especially the protein assays, are not that expensive. And the platform we use is the same one that's in your tissue typing laboratory right now. So it's the same machine. It's relatively low cost. And then basically you get down from 32 of these targets down to a kit that has 4 or 5 that are relevant to the clinical question. And then that starts to bend that cost curve. The other piece of that is you have to, we have 3 big systems. We have, you know, us up at Walter Reed. We have Duke and Emory. You have to use these within your system. Because if you're not using them within your system, then no one else is going to want to adopt them as well. But I think the couple, you know, basically being smart about the reagents that you use, using it within your system, you can actually make, and using those cost numbers that show, hey, that one critical decision has a downstream effect, that'll win. If you look at the wound closure decision, if you make that right decision of, hey, do I close that wound now versus later, that's 2 less days in the ICU, 5 less days in the ward, that's 3 less interventions by the rehab folks, and a 15% reduction in your risk of hospital-acquired infection. If you add up those dollars, that's $60,000 per patient. So you have to go after those high-risk decisions. I do think the future actually will be different. I think these assays will become so low cost that you'll basically run all the targets on everyone that's sick upon their admission. I think that's in the future, but I don't think it's that far away.
I'm going to have Dr. Lloyd give our last question. I hate to cut off this great conversation, but...
Thanks. I'll try to make it quick. On one of your slides, you mentioned the lack of T0 data. And, you know, as you know, the importance of data is not merely the day-to-day data point, but how the data is changing. Do you think you'd comment a little bit about how you could apply your system to obtaining data before a military person becomes a patient, maybe to those high-risk potential persons maybe going before they go to theater and high-risk environment?
Yeah, so essentially the question relates to T0 and having, quote, a control population. And there's several ways to look at that. For the military folks, actually those of us in uniform, we give a blood sample upon a session, and that gets stored in the Defense Serum Repository. Now it's only serum, so that becomes, you know, you can't run everything off of serum. And we've actually looked at the DSOR as a way to capture someone's, you know, baseline. But actually the way there's multiple ways to look at those control groups. One way that a lot of people use is healthy controls. We'll just take half the room here and have them give samples, and that's our controls. The problem with those, quote, healthy controls is who's really healthy, what defines who's healthy, and how healthy are they. The other way to look at it is, you know, one group that develops a complication versus doesn't. One of the ways in these wounded warriors we've looked at is say, okay, we got a group here that are kind of on the normal trajectory. Those whose wounds don't fail, who don't develop heterotopic calcification, who aren't infected. They're kind of the normal pathway versus those that have a derangement. So there's many ways to skin that cat, and you have to be aware of all of them, have data for all those approaches, and then, you know, tailor them appropriately.
So I just want to thank you again. Thank Dr. Myers for leading our precision medicine effort here, and Dr. Galante for bringing you out. And we look forward to spending some time with you today.
Thank you very much.